Hello and welcome to today's Fightback Session. I'm Lily, I'm the coordinator of this event series, and I'm with FoundersLane, the founders-driven corporate venture builder. And while everybody's dropping in, let me tell you a couple of words about who we are and the mission that we are in here with this live event series. So at FoundersLane, we approach today's challenges with an entrepreneurial mind and results-driven action to co-create a better world. And fightback is the word that we coined in this context. And in these present times of massive business disruption, we want to contribute by hosting these free trusted spaces to equip our business leaders and their companies with actionable insight and advice to not only survive, but really thrive in this new economy that awaits us. And today's conversation is about digital healthcare and its challenges. Now, let me hand over to your host, Sven. The stage is yours.
Hi, everybody. Welcome. So I'm Sven. I'm in charge of the health vertical together with our co-founders, Andreas, Felix, and Michael. Corporate venture building is a new asset class next to CVC and the other things that you know, where we bring entrepreneurs together with corporates, which works particularly well in areas that are highly regulated because entry barriers are high for startups. But enough about that. Now let's move on to Anant. Maybe would you like to introduce yourself quickly?
Thanks, Sven and Lily. So my name is Anant. I'm currently a researcher at the University of Oxford in the Department of Primary Care and also at the Oxford Martin School. And before that, I ran a company called Better Value Healthcare for about 9 years. We work with governments to help them redesign their healthcare systems to focus more on value-based healthcare. And we worked in England, Scotland, Wales, Germany, Italy, Spain, a little bit in the Netherlands. And then we also have collaborations with colleagues in Singapore, in Hungary, in the US as well. And before that, I was a molecular immunologist. Did my PhD on B and T cell development and function. So quite a weird trajectory for my career.
Thank you. Maybe just about myself, I think I know a few people, but I'm a medical doctor, then studied also public health, public policy, became chief medical officer at a venture of Helios Clinic, which is Europe's largest hospital group with over 100 hospitals in Germany and Spain, and now in charge of the digital health sector at FoundersLane. What we want to talk about, one is starting from a broader context and then moving into implementation challenges. But what we're mostly interested in is actually having a conversation with you people. Please feel free to chip in questions in the chat and we'll be more than happy to discuss them. But with no further ado, here's from Anant first.
Thanks, Sven. What I'm going to be talking about in a few slides is the population health perspective. So healthcare innovation, the ecosystem may be moving fast, but the problems that our citizens are facing are still the same. And that is quite nicely exemplified by this study done in 2018 and was published in the BMJ. And this headline was from Reuters. A life expectancy declines seen in the US and other high-income countries. Out of 18 countries in this study, 12 experienced life expectancy declines among men and 11 experienced life expectancy declines among women. And that seems quite shocking because these are high-income countries and they're spending a lot on money. And the US, which is where I'm from, I currently live in Oxford and I've been here for 10 years, but I was born and raised in the US. And, for the past 3 years, life expectancy has declined. We spend more money on healthcare than any other country in the world, and we have fantastic technology, etc., yet life expectancy is declining. Of course, there's questions as to whether life expectancy is the best metric of health, but it is still telling that other countries are doing better than us. So what's going on? Well, it's important to note that clinical care, so access to doctors, hospitals, etc., only accounts for 20% of health outcomes. So these are health outcomes, policies, programs related to health factors related to health outcomes. And health outcomes are defined as length of life and quality of life. You see that clinical care only contributes about 20%. The other 80% are through health behaviors like tobacco use, diet, exercise, etc., social and economic factors, education, employment, physical environment, air, water quality, housing, and transit. And one of the things that we're seeing with COVID, which is quite interesting, is air quality across the world actually improving. And Sven, as a respiratory physician, probably appreciates this quite a bit, or former respiratory physician.
Right.
Digging a bit deeper into this, this is Jeffrey Rose, who in 1985 wrote a fantastic paper called Sick Individuals and Sick Populations. And you can see a link to his article down here. Basically, what he talked about was the distinction between looking at individual risk, so people who are at high risk of having adverse outcomes, versus looking at the population. And his thesis was that by looking at the population, you can actually control the causes of incidence of disease. So rather than having to wait for people to get sick in the first place and then trying to scramble to solve their problems, we could control who gets sick in the first place. And he sort of exemplified this in this very simple graph where you have risk on the x-axis and you have the percentage of the population on the y-axis. You have a standard bell-shaped curve, and you can see that the high-risk population is over here. And the risk reduction approach is to try to get this high-risk population into this medium-risk category. Most healthcare systems across the world focus on this approach because these individuals are high at risk. So obviously, if you intervene for them, you could potentially reduce the amount that you have to spend for them. But what Jeffrey Rose says is that if you actually want to look at the health of the population as a whole, what you should be focusing on is shifting the entire risk profile to the left. And when you do this, you'll notice that what was the highest risk population is now in the sort of medium risk category. And these risk bins are also important because you need a different level of intervention for each of these risk bins. You need a high level of intervention for the high risk bin. You need a relatively lower level of intervention for the medium risk bin, and even lower level of intervention for the low risk bin. So by shifting the entire profile to the left, you improve the health of the population, and you also reduce the amount of intervention that you need to do. And so this comes into this sort of trendy business concept that's around nowadays, around the theory of change, where you start with impact, outcomes, outputs, inputs. I won't go into detail, but if we just focus on the impact, using the Oxford English Dictionary definition, the definition of impact is to have a strong effect on someone or something. So if we dig a little bit deeper into that, what we'll realize is that any action has an impact. So looking at this simple table, you see you have intended impact and you have unintended, and you have positive as well as negative. And the unintended impacts are what are called externalities in economic terms, which you guys are probably all familiar with. Now, ideally, what you'd want to do is to maximize the positive intended impacts of whatever actions or interventions you're creating. But it's also important to realize that your actions will probably have some intended negative impact, because any intervention in healthcare can do good, can do nothing at all, or can do harm. And then there's also the negative unintended impacts of your actions. And last year, there was a really interesting set of studies that were done on the impact of AI algorithms. And what they found was that the carbon footprint of AI algorithms was actually eye-watering. And this was from a study. We can send the link to the study afterwards. But training a single AI model can emit as much carbon as 5 cars in their lifetimes. It's an interesting concept, and obviously that's the negative impact of training an AI algorithm. What that has to be balanced against is the benefits that the AI algorithms actually bring to the market and to benefit patients and citizens. So if that benefit outweighs this cost, then it's probably okay. But it's important to keep this in mind, because oftentimes this is just an unintended negative externality. So it should be moved up into the intended negative outcomes so that we can actually account for it and offset it if we need to. So what does all of this have to do with precision medicine? We talked about population healthcare, trying to shift the risk profile to the left, looking at impact, et cetera, et cetera. For us, I think one of the key areas where we think digital health can really push things forward is in this realm of precision medicine. And that can be done at an individual level or a population level. And the NIH definition of precision medicine looks at accounting for genes, the environment, and lifestyle for each person. And precision medicine can then be sort of pushed forward to precision public health by replacing person with population. And Clayton Christensen, who passed away just a few months ago and was a professor at Harvard Business School, had this really nice sort of heuristic way of looking at the evolution of innovations in healthcare, where we go from intuitive medicine to empirical medicine to precision medicine, where intuitive medicine is medicine as an art. Empirical medicine is where most medicine is nowadays, which is the differential diagnosis. So if you've seen House, somebody comes in with a symptom and they do a bunch of tests and say it could be disease A, B, C, or D. They do more tests and say it's probably A or C. They do yet more tests. House has some, fantastic intuition and says it's actually A. And then you're able to actually treat the patient. With precision medicine, we have the exact understanding of the disease of the individual, and we can give them a precise intervention such that there are no side effects. And for us, I think digital health can be a huge driver and boon in this area because it can account for so much data and the individual nuances of a person. And then it can also take population characteristics into account. So going back to the original statement, a healthcare innovation ecosystem may be moving fast, but the problems our citizens are facing are still the same. So if we look, again, going back to the diagram, only 20% are due to clinical factors, 80% are due to social determinants of health, so health behaviors, environment, lifestyle, etc. And when we're taking that into account in a precise manner, which can be done via digital health, we can actually impact our patients and our populations and our citizens in a much more profound way. But one thing to realize is that digital health is a means to an end and not an end in itself. So not all digital interventions will actually be beneficial for the population. So with that, I turn over to Sven to talk more about the innovators side.
Thank you. Thank you very much. So basically, if we look at the macro perspective of what's going on, we are seeing that just throwing more science and more CT scanners and maybe antibiotics at the problems that we have at the moment is not helping. It's only giving incremental improvements, and we're reaching limits. We're reaching limits of feasibility, of affordability, and so on, which starts to push us more and more towards thinking in new ways. And one thing that Anant pointed out is that we need to move beyond what we like to call the biomedical box, which is going out of the thinking only in sort of the hospital and the doctor world and moving more into what are all these other determinants of health, more the social determinants. And when we come to precision medicine, it's something that really tries to allocate resources to an individual in a sense that you get the best outcomes for the least amount of investment, whether it's time, resources, money, or whatever it is. And these things only become possible really now thanks to digital technologies, because we have devices that can collect outcome data from patients through surveys, for example, or by using all of the sensors that you have in your phone, because we have analytics that are much more powerful than anything we had before that allows us to really give personalized recommendations to individuals based on empiric data, based on comparable data sets from other patients and so on. Another thing that we can take from Anant's session is that we have to be in love with the problem we're trying to solve and not so much in love with the solution, because it's not always AI that will help us. It's not always digital that would help. Sometimes it's something that's maybe just a rules-based engine, or maybe it's something completely offline that will have the biggest impact. And we always need to consider that. Now, I want to talk more about what do these macro level implications mean for healthcare. And why is it that healthcare is still such a laggard? Because it does lag behind a lot of other industries. And I recognize that we have quite an international audience here, so please forgive me if you think that some of these things don't apply to you, and I'm more than happy to discuss these differences as well. I operate mostly in the European space, so it might just be different for you, but maybe still interesting to have a reflection on these sorts of things. The first observation is that if you would look at the state of healthcare apps in an Apple shop a couple of years ago, you would find around 100,000 apps, which is quite a lot. And it was fairly straightforward to delineate them and to say, well, there's a big bracket, which makes up the majority of apps that are purely in the wellness space. These are your fitness apps, your mindfulness apps, maybe your sleep tracker, maybe a nutrition book or something like this that aims to help you healthier, make you happier, but they don't really have a clinical value proposition. And then you have the real health apps, software as a medical device, as it's called, which is highly regulated, which would be your diabetes guide, or maybe a device that helps you optimize your medication and so on. And there were fewer of those. But then what happened over time, this should get bigger and these should move towards each other so that you end up having a circle here that is larger and having a space with a big overlap, where suddenly it's becoming increasingly difficult to tell whether something is a wellness app or a health app. And that can go both ways. So suddenly you have wellness apps that seem to be very innocent, but all of a sudden they go into the field of actually becoming treatments where they can also have much more harm. And you have health apps who suddenly become more user-centric, more gamified, and so that blends. And I will talk a little bit about why this might be problematic from an innovator perspective. So I'm sure that all of you are quite familiar with these three circles of innovation, which is often quoted in the design thinking space. They say that if you want to be in the sweet spot of innovation, which is localized just in here at the intersection of these three circles, that means that you have a solution that is desirable, which basically means people want to use it, it solves a problem for them, or it delights them. And then it's also feasible in the sense that It's technologically possible, it's legally possible, etc. And it is viable so that you can actually make a profit out of it. So you find somebody who is willing to pay you enough for you to make all of this venturing viable for you. There's a problem with that if you go into healthcare. If you think of, let's say, a vape, something like Juul, they are perfectly desirable, they're perfectly feasible, and they're viable. The company became quite wealthy with it. But it ends up harming people. Or you might have, let's say, a defibrillator, which is feasible, is viable, but it's probably not something that patients would actively ask for. Or if you think about drug-eluting stents, it's not something that has been invented because patients actively ask for a drug-eluting stent. That came from science. So if you go into the healthcare space, we argue that you pretty much need a fourth lens to guide your thinking, and that's the effectiveness lens. That's how clinicians, how researchers think about developing a new drug, how the drug-eluting stents came about, and so on. And it makes things a little bit more complicated. So if you are somebody who's innovating and you just want to do things that don't really have a value proposition for somebody's health, then I think you're perfectly fine with these three lenses. But as soon as you enter the other space where it's about treatment and you could put people at actual harm, you have to bring science to it and to gain an evidence foundation for what you're doing. And if you are in the healthcare space and you moved more towards the wellness side, then it's becoming difficult to keep your agility and these things where you're not really having an impact on somebody's health, but you're more doing the gamification part or the design part, the empathetic part. And I just realized that a lot of times developers, even if they're extremely smart, they struggle with this concept of giving a science base to it. We can talk more about this later, but I just wanted to raise awareness about that. We can talk about how to deal with it, how to operationalize it later. There's another issue, and that's we have two curves here. If you're in the business of sharing cat videos, if you're the maker of, let's say, YouTube or Tumblr or something like that, typically what you can sell to your investors is something that looks like an exponential curve. You've all seen it. It starts slowly and then suddenly you have the hockey stick kicking up. If you're in healthcare, what it often looks like, it's much slower. It's more of this S-shaped curve. It doesn't go up quite as steep. It takes longer to rise and so on. And this would be something, let's say, you're reducing hospital-acquired infections. And it's much slower because your adoption rates take longer. Hospitals have very complex buying systems. You often have, we'll talk about this later, a set of actors that you need to convince. And your overall market isn't quite as high. Plus, because of all the regulation, it's really expensive to even get a right to play and so on. So that is a bit challenging. Another challenge you have is the age brackets. If you imagine this is your overall population and it's mapped against the age, then if you look at where most of the chronic diseases are, you will find it is quite skewed to the right, to the elderly people, where you will find people with a lot of multimorbidities. And these are the people who would actually need your help as an innovator the most, because their burden of disease is probably the highest, at least at the moment. But the level of digital literacy, those people who really feel comfortable using your AI, your augmented reality, or whatever it is, they're typically younger. So the overlap of the people where you can help them solve a problem and who would be able to use a device without any major issues is again a bit smaller. Now, if you go into the prevention space, then it might actually make perfect sense to go here, because at some point you will be here and then we go back to the curve that Anant showed us earlier and you will be able to shift this curve further to the left. But from a business perspective, you obviously want to go where the pain is the biggest and you hit a natural problem quite often. What's the next problem? You have a very complex system that you need to convince. And the first triangle here basically argues that you have to understand that there's not the one customer. The patient typically would expect that the provider, so doctors, nurses, recommend the tool to them, guide them on it. If doctors say, what you've been doing here with your app is complete rubbish, chances are they're gonna turn away from your tool. And then you need to find somebody who pays for it. So if you're in a Bismarckian system like Germany, the expectation usually is that if something functions, it's the insurance companies who pay for it and not the individual. So you will have to craft a value proposition that is charming to all three of them. And if you zoom into the provider, then you come to this second triangle, which is on the right. That tries to illustrate that you have three major groups of buyers that you also need to woo. The first one being your user buyer. Most likely it's your doctor, your nurse, your therapist. These people just want to know that what you do has an efficacy, that it's scientifically proven, that you maybe save them some time, but at least you help them deliver on what their value proposition to their patients is as good as possible. And then you have the technical bias. This is your IT department who will immediately ask, wait a minute, is this an IT project I'm getting on my backlog right here? I have enough to do already. How is data protection going on here? Is it safe? Do they know what they're doing, etc.? So these people, they probably want as little work and as little headache as possible. And then you have the economic bias, and those are often your managers in hospitals. And some of them told me, if you don't have a means of proving to me that within 2 quarters, so within 6 months, I will have a positive return on invest, then I don't want to talk to you. And that's often difficult. So what do you promise, right? If you say, I'm going to make your patients better off, then they're going to say, okay, but I'm not going to get paid more for this. So what is your offer? If you say, I can save your staff 10% time, they might say, well, thanks, but 10%, I'm not capturing it. I'm giving these 10% to my staff, but I don't have any advantage from it. So sometimes they expect you to reduce somebody's work by 50% so that they can downgrade them from a full-time to a part-time employee. Or they would expect you to show that a patient can be discharged one day earlier because that's something that they can measure. That's a bed capacity that gets freed up, etc. So it's often really about understanding what exactly are the value drivers for these three and for those three. Then there's another issue. So this is the German context. Apologize if this is not relevant. I once gave a talk with some others and we complained not about the general data protection regulation. That's fine. We complained that the authorities were unable to give clear advice and guidance on what is okay and what is not allowed to do. And at some point, somebody stood up who is from the German Federal Office for Information Security, so the highest authority for that. And he just said, we don't want to stifle innovation. We just want to protect people's data. And as soon as a business transaction is over, we think you should delete that data. And then he proceeded to give an example, and he said, so for example, if somebody leaves the hospital, you don't need the fever data anymore. And another person stood up and said, oh, wait, are you deleting my fever data? I want to have a right to donate my data for research, and you're depriving me of that. And I said, there are good reasons for keeping somebody's fever data. If you have cancer, if you have malaria, if you have rheumatic diseases, I want to see how your fever develops over time. And that just shows that even if you have the best laws, you need the authorities who are able to really deliver on it and to give you the right guidance and orientation. And that's something that I've seen in only very, very few places on the earth. I think the FDA is doing quite well, but maybe people have other experiences with that. And this is something where Anant and I thought about what are the rate limiting steps. And sometimes they're not just rate limiting, sometimes they constitute prohibitive barriers, at least for the smaller and medium-sized enterprises. And the first one is you need a very diverse team of people. It's not enough to have good experience in e-commerce. You need experience, you need somebody who knows something about the healthcare industry, for example, and you need a diverse team. Testing is extremely difficult. It's not like in fintech where there are regulatory sandboxes and you can try out things in a safe space. You need an ethics committee, etc. Then if you move to the next stage, which is adoption, we go back to the barriers that I said before. You need to have an inclusive design for elderly, or you try to find something for the younger people. You might have a very risk-averse group of people who prefer not to make a mistake somewhere rather than being too permissive and then there's an innovation that went wrong in one way or another, because it's always people who are at harm. And somebody said, insurance companies and healthcare providers these days, they're kind of like venture capitalists. They get pitched startup ideas on a weekly basis, except that they have no idea how to judge them. So they don't know how to do due diligence, and they're over flooded with information at the moment. And then when it comes to the last bit, like how do you make money, even if it has been adopted, you will find that most systems have very strong gatekeepers with vested interests that they probably don't want to get disrupted, and they are in healthcare often in a very good position to defend themselves thanks to regulatory barriers that are in their advantage. Evidence is often not enough. We see that even in the pharmaceutical industry, you might have a big clinical trial, and they would still say, well, we're not admitting this new drug, or we're not giving you the money that you had hoped for. It's going to be much, much less. And we don't know yet, even in Germany with the Digital Care Act, how the negotiations are going to go for how much a software developer can actually charge from the insurance companies for their tools. Something that I keep hearing over and over, which is a little bit sad, but it's, I guess, reality, is while you obviously try to create benefits for your patients, what will help you get adopted and paid for by insurance companies, etc., in probably most places of the world, is when you also have good evidence of economic benefits, which is what I mentioned earlier, something where they really see how they can save money somewhere, or make money, or save time in a way that is significant enough to really matter also to those who pay for the show. And final two bits is that a lot of the value you create in healthcare is really, really hard to measure and to capture. So you might be creating a lot of value for other people, but you see all these things where they say sleeplessness costs society billions every year. But what does that mean? Does that mean you have a market of $1 billion or $2 billion? Probably not, because it's so multifactorial. It's so hard to capture. If the billions are incurred in cost because in parts people are less productive at work, but you're not going to charge an employer for your tool to help somebody sleep better and so on. So these are all these things to think about when you write your pitch deck. And the final thing is, I think that a lot of the venture capital mindsets are maladapted to healthcare. They expect these very steep exponential curves, and that's simply not what's happening in healthcare. It takes much longer, and you might not have the same upside. But you can have recurring revenues over a longer time, might be more stable, and you create a lot of social value potentially. Not going too much into detail about this, but this is another case in point where regulation is executed poorly. In a previous role, we were often in conversations with the state data protection officers, and we just realized that they completely refused to make any statements on whether we're allowed to do something or not. At best, they would say something verbally, but say, I'm not going to write this down for you. I'm just not going to say something, because they're all afraid of being the one who has been too permissive and then something went wrong, and they often don't understand the complexities of machine learning and all of this. Be prepared for those guys, and also be prepared to find a clear way of communicating to them. Don't make it too complicated, even if you're excited about the tech you're building. One thing that we think about a lot, what we're trying to say here, is that good innovators in healthcare often have figured out how to put things on the timeline. Let's say you want to build something that diagnoses cancer. You're likely going to be in the tier 3B space down there, where you are super regulated. This is, by the way, from the NHS tiering system. But you can do something where you are the biggest, most heavily regulated medical device. But you don't have to start with that. You could start with something where you even no medical device at all, where again, maybe in the wellness space. And you use that to validate a lot of your assumptions on, am I building the right technology? Am I being empathetic about how I build things? Am I targeting the right audience, etc. And as you validated your first steps, maybe you start with a mindfulness app and you end up with an app for therapy of depression. But don't try to do the big complicated things that are very regulated right from day one, because it's what everybody talks about right now. We thought we also add in one slide with a few thoughts on outbreaks and what can technology do for outbreaks. First of all, a lot of people think, and there was a new science publication, I think today, that came out that says that COVID is here to stay in all likelihood, maybe until 2022. And even if not, there will be more outbreaks. So probably this is something that we will keep thinking about often as a society and as individuals. And there's a lot we can do. One thing is, if you think again of the curve that Anant showed us earlier, that is being left shifted, the healthier we are as a society, and the more we work on prevention and the better our lifestyles, the more resilient our systems will be, because then we're less likely to die from such an infection. And I think that a lot of the business models and a lot of investments and maybe also insurance companies will think more and more about shaping more resilient societies by making them healthier and advancing prevention, more than it has been the case before. We have also been at FoundersLane, we've been contacted by somebody who manages refugee camps. And they were extremely concerned that they have some points, for example, where people draw money or where they have some other physical interactions. And they said, we need to make these interactions touchless, because if this becomes the center where everything breaks out, we have a big problem in these camps. Then another person came up to me, a cardiologist, who said, I don't want to follow up on my patients that I give a stent or something, or that I saw in the hospital. I don't want to follow them up in the hospital because they are way too much at risk from COVID. So I need telemedicine. And they tried a lot of things and it didn't really work out and so on. So they were concerned. So what I'm trying to say is that I think there's more acceptance of remote care, of moving the center of gravity away from the hospitals, and of thinking more and more about avoiding unnecessary touch points. Another thing that probably is happening at the moment is that we realize the power of data. People have used Instagram posts to track infections by looking at where did people take pictures, etc., who were they in touch with. This can be massively abused as well, but I think there's a lot of opportunity in helping track outbreaks, diseases, and so on. And that goes back to Anant's earlier point on, it's not just about digital. what's really important is to have the right infrastructure. Infrastructure being your physical infrastructure, the streets, the transport, etc., as well as the digital infrastructure that allows us to communicate with big data sets. I mean, just look at the amount of webinars and teleconferences that we're all having at the moment. And it's important that we have all of these. And it is always important whenever we talk about digital solutions that there is a backup for those who can't jump on the digital solution. And that's also something I think that we as innovators are more and more asked to do, is being inclusive in our design, making it accessible, figuring out ways where people who have visual problems or hearing problems or maybe problems typing, that we make it available for them. So that calls for more and more voice recognition, bigger displays, and what else. So this is it. I don't know if you have any other comments. Otherwise, I would like to open the stage. You can type in questions if you like. Tim, what do you think can and should governments do to ensure a resilient society? Do you want to take this one, Anant?
Yeah, sure. So in terms of what governments should do, we should be investing our money in different things from a governmental perspective and focusing more on the things that actually keep people healthy. So how do we ensure that everybody is educated to a high standard such that they are employable? How do we ensure that there are actually jobs on the marketplace? How do we ensure that there's enough capital floating around in the marketplace such that they can that capital can be invested efficiently and effectively into small businesses so that people can create a livelihood for themselves. When something like this happens, I think Germany, in terms of their unemployment methodology, which the UK has also adopted, which is this furlough system. So, instead of the companies needing to fire their employees, the government takes over their salaries for 2 or 3 months. That's what the UK has done as well. The US hasn't done that, which is why 16 million people have had to file for unemployment. Now, there are certainly a number of people in the UK that are filing for unemployment as well, but nowhere near the level, even proportionally, as the US. So I think there's a lot of things that governments can do, and I think it really depends on, making sure that they're prioritizing the right things. I don't know. I don't want to ramble about that because I see a lot of other questions. Sven, do you have any other thoughts on this?
No. I think it's very good. I'll probably go to David's and Terry's questions. So David is asking, can you tell us about startups and companies in the health space who nailed it in at least in the last quarters? The one that comes to my mind, I think, is Dr.24, which we had, I think, was it last week? They are a provider of digital health, of telemedicine, but also a lot of automated solutions. And what they've seen right now is a very strong rise in demand because people, they sit at home and they have some symptoms where they're not sure if it's COVID or not, and they want a quick answer. So then they go on the platform, they have a questionnaire, and they get the answer that they typically need, or they can talk to a doctor. The other situation is that now people have the problems that they would have anyways, back pain or I don't know, we have a lot of allergies going on right now, etc. And they also need help, but they don't want to go to a hospital for it because they're afraid that over there they might be sitting next to other people who are actually infected with COVID. So there's more of a need to stay at distance, and most of the telemedicine providers have benefited from it because they provide a solution that's quite in demand for this. So yeah, I guess those would be my winners at the moment. And then the next question from Siri is, I'm aware of some tech startups who have pivoted away from providing healthcare solutions to focus on other sectors because it's too complex. How can they be supported to stick with healthcare? I fully agree. I know a couple really, really smart people with beautiful solutions, and they took the same solution to another problem and suddenly became wealthy, or at least don't have to struggle quite as much. And that, I think, is a tragedy, at least for the health space. How can they be supported? I think we need institutions, public institutions, who dare to give clear answers, even if that means that maybe sometimes they might be making a mistake. But we need orientation so that we know what we can do. I think we need more education. Doctors are completely not trained for anything in the digital space. Our education is still fit for the 90s probably, but not for what's going on right now. And I see that a lot when I try to hire doctors for our portfolio companies and so on. it's often a disaster. They completely maladapted to digital innovation or business worlds and so on. And then I think the third dimension is we need funding that allows to pay for clinical trials, for medical device certifications and so on, which is not typically factored in. Just yesterday, I spoke to somebody. I helped an angel investor with due diligence on a startup, and they completely forgot to mention that they might need FDA approval, which might cost them another 150K or something like that. Like significantly increase the burn rate. So yeah, maybe that could be a government thing. Maybe that could be something that VCs should think about.
One other quick thought on that is just I guess the people who are coming into the tech space, at least the tech guys, not the medics necessarily, but the tech guys have a set of transferable skills that they can use for any sector, which is why they're able to jump. And so that's interesting. Maybe a counter way of thinking about that is, what is the proportion of people who could actually create an innovation for healthcare, but they dare not even enter into the space? So the sort of lost opportunity of people with those transferable skills. And I think, Sven's points about creating that ecosystem and that environment that is more supportive to actually allow those innovators to be able to innovate and work in the healthcare space is quite important, because there's a lot of fantastic ideas that we're probably missing out on that we don't even know.
Do you want to take the next two ones, Bart and Mihir?
Yeah, so are doctors a disaster, or is it the innovator not understanding the culture and value system on which healthcare is built on? I guess it's probably, a cop-out answer is probably a bit of both, right? I think the innovators, they have a set of transferable skills, so they can innovate and create solutions for all sorts of problems. But the question is, are they asking and addressing the right problems? And sometimes the issue on the doctor side is sometimes they're not able to actually articulate the key issues within the system itself, because they're so focused on firefighting and seeing their individual patients that they don't see the forest for the trees, and they're just thinking about, oh, how do I solve this person's breathlessness, rather than looking at the root cause, like Jeffrey Rose would, which is to say, why are these people breathless in the first place? And then how can we actually work with the tech community to actually identify these people before they get sick? So rather than intervening when it's already too late, how can we reduce demand? So I think one of the problems of healthcare in general is, if you have supply side, demand side, we're typically just focused on supply side. How do we get more doctors? How do we get more tech? How do we get more nurses? How do we get more hospitals? How do we get more beds? But we're oftentimes not focused on the demand side, which is, how do we prevent these people from getting sick and needing care in the first place, which is the sort of notion that Jeffrey Rose would talk about. So, I think it's a complex answer. And I think, even training doctors to think a little bit more holistically and broadly about the population would be good. And then having the innovators being exposed to this type of thinking, I think would also be helpful. But I think a lot of the stuff that Sven actually talked about are the things that would prevent people from actually going into this. So, for pharma companies, or for us even, reading evidence all the time, it's fairly easy, it's fairly not easy, but it's normal for us to think about phase 1, 2, 3, 4 clinical trials. But for somebody coming in, and this sort of relates to Carrie's question, coming into this fresh, it's quite a daunting thing to think that you have to do a clinical trial. How do you actually set one up? What is your control? And what outcomes should you actually be looking at? And then there's also the question of attribution. So if your digital solution says something wrong, then who's at fault? Is it the doctor who used your solution, or is it your solution itself? So there's litigation issues and all sorts of other points there. And then, in terms of the money, investors are going to be looking for a return on investment. And again, as Sven pointed out, if they're looking for a return on investment in this hockey stick shaped portfolio, it's not realistic. And I think one of the problems in digital health is that you have investors who are investing in digital, and in healthcare, like in pharma, you'll have people investing in pharma who are, in their minds at least, ready to wait for 10 years before they see the true return on investment. And I think there needs to be a match between those two before we can get digital healthcare into that little, intersection of the 4 circles that Sven showed, where we're effective, we have good evidence, it's desirable, it's viable, but that takes time. So I think that's sort of a culture shift for investors, for innovators, and for doctors as well. Do you want to take the next?
Yeah, Thomas.
Yeah.
So Thomas from Austria apparently is saying that it seems like COVID made a lot of things possible that previously were defined as impossible, at least in Austria, like electronic prescriptions, online pharmacies. Do you think those are going to stay after COVID, or will those be reverted? Well, I guess the honest answer is it's too early to tell. But what we are seeing is that, let's take telemedicine as an example. To be honest, a lot of doctors have been using telemedicine quite a lot. And most of the doctors, if you ask them, they have received questions from their relatives via WhatsApp or a picture somewhere, and they have been informally asked to do something that is telemedicine-like, and they did it. They just didn't do it for their actual patients. And now with the pressure coming up, where there's real harm, that can potentially come to the patients, both the doctors and the patients are more willing to go new ways. And for behavior change to kick in, they say you need at least 30 days or something like that, or 4 weeks. Sometimes it takes longer, but it seems like we are in this for a longer time, and that we will get used to a different way of interacting in many ways. And I think that is something that probably is going to stay. Typically, if you look at how long it takes to develop a new vaccine, it's 9 to 15 years. And now everybody is talking about a vaccine for COVID coming up in a year. We have to see if that's going to happen, but I really applaud the efforts. And I think if we have proven to ourselves that we can deliver innovations, and it might not be the vaccine, but maybe other things, if there is a sense of urgency, that we can make it in a safe way, I think that in the future, you will often hear something where, this worked during COVID. Why shouldn't it work now for cancer? Why shouldn't it work for, I don't know, something else? So I think we will be less able to shift blame on systems or whatever it is. So yeah, I'm actually quite hopeful. It's a tragedy, but I think we are learning some good lessons from it. Do you want to do Timor's, or should I quickly revert to Bart? I get it, Bart. You're right. I don't want to put all the blame on the doctors. That's Bart's pushback was that. Wait, things are jumping. I'm sorry. He sees a lot of innovators in Europe that are importing a value system from the US into a European healthcare system. And if there's one thing we learned during the last 6 weeks, it's that we should not thrive on doing so. I think alluding probably to how the US is managing the system, but I'm interpreting here. And yeah, obviously. A lot of what I see also is that there's a lot of naivety from people coming from outside the healthcare system who don't take the effort of really trying to understand and to talk to the people who work in the field. And that is not just doctors, that's nurses, that's even informal caretakers and physiotherapists and so on and so on, and the patients. However, I'm a doctor myself, and I think we have to change too. I don't think we can just sit on our high throne and say, until you guys understood us, we're not going to accept whatever you bring up. A lot of innovation comes from cross-pollination, and not everything that is happening in the US, I think, is false. I took a really nice course on empathetic design at Stanford last year, and I think we have a lot to learn from it. And I do believe that it's probably a good idea if doctors understand better what all these apps are. And they're asking for it as well. They want to have more trainings to understand what to recommend to their patients and what to look for and so on, because it is something that they're not trained for, and it's something that patients start demanding.
A reinvention in terms of innovation and digitalization when it comes to solutions for hospitals and district-located doctors. Before we invest in ML, AI, or would you prefer to see solutions that slightly wrapping these entities? Which are the key protagonists need to change most rapidly, and how? So I suppose that's a question of inequality or equity and inclusion. It's an interesting question. We work with some local authorities, for example, who provide care for people in rural areas. And they were testing whether Amazon Echo, for example, could be used to deliver care remotely to individuals who are living alone. And they got some mixed results. And I think one of the problems they had was it was very expensive to actually send people physically there, and so they wanted to use technology to see whether they could actually augment and substitute. I think, in answer to your question, the first thing that I would start with is what outcomes are we trying to deliver as a starting point? And then, as a matter of equity, particularly for a universal healthcare system, which might sort of relate to Bart's question about Europe versus the US, in a universal healthcare system, we have a mandate to provide care to the entire population at the point of need and within a finite budget. So the first step we should start off with is, what are the outcomes that we actually want to deliver for our populations? And then there's the question of the how. So the what first, and then the how. So for people in areas where they're closer to a hospital or better facilities, they might have high tech or face-to-face delivery of care. For people in rural areas, they may have other means by which they're getting the outcomes, but they should still get the same outcomes. So I suppose, from looking at it from two perspectives, from an equality and equity perspective, we should do the first thing that you're describing, to make sure that all of our citizens have access to the same outcomes. And that might mean that we have to prioritize creating technologies that can actually deliver care to these individuals who are far away from a hospital and might need remote care. From the other side, when you're thinking about sort of trickle-down effects, by investing in resources and trying to develop technology for urban centers where you already have a lot of resources, you might be able to create the type of technology that could also benefit the rural areas, even though it may not be directly related to trying to deliver care or reducing inequalities or inequities. And the reason for that is, from an investor's perspective, from a market segmentation perspective, you have a higher population in urban centers, and so you might be able to drive things forward faster in those urban centers. I don't have a clear answer to that. I mean, I suppose it's a societal question, which sort of goes to government priorities and things like this, and what society would actually prioritize. So, like Sven mentioned, Dr. 24, I think, is a great example of something that can actually deliver care remotely as well. And that's sort of a solution that can be used across the board. And, there might be solutions like that as well. I don't know if I answered your question correctly, Timo, but if I haven't, please, add in a follow-on question in the chat. Is there other more questions?
Yeah, I mean, here is an interesting question. I'm just thinking maybe that's for a separate webinar. Basically saying, how can we use the momentum from COVID to fast implement change? Yeah, I would like to get back to you on this. I think we should do a separate session on this. I think it needs a different format with more verbal interaction, probably.
Yeah.
And then we have Ben, who says, in my view, in addition to prevention, the physical encounter between people will remain relevant in the future. Healthcare depends partly on human attention. How do you see that? I wholeheartedly agree. It's something that I think Anant and I as individuals strongly believe in, and at FoundersLane clearly as well. A lot of what we do in healthcare, whether it's the physical examination or auscultation or whatever, is important because it gives you very important data points, but it is also a ritual, and humans need rituals. You have that in every culture, in history today, because rituals are there to signal transition from life to death. For example, you have funerals, from being single to being married, etc. And we also need the physical encounter as a ritual to signal a transition from health to disease, or from disease to health. And these things are extremely powerful. I also think that it is important for the doctors to have that personal interaction. You need, I think, or at least many people, thrive on the true human interaction. And if it's done well, probably some argue it can be a driver against burnout and so on. And I see an opportunity in this. If you look if you go into an Apple store, a physical Apple store, you will find a lot of technology, but you don't see it because most of it is in the back end. And it will take you, I don't know, less than 30 seconds until actually a human person comes up to you and starts talking to you. And that's only possible because they have all the technology in the background that maximizes for human interaction. And I do think that this is something that we can also do. So yes, we need to create a more touchless society for care when it's needed. But yes, we also need to make sure that there is the space for people to interact physically and to have that human component. But I also believe that you can have a lot of human touch, a human interaction through digital means, if the other one is not possible.
I mean, you can almost, presumably segment the population into finding out, who actually absolutely needs a physical interaction and who doesn't, because there's also this notion of the burden of care. I mean, having to drive to the hospital or to the waiting room or to the GP surgery, and then waiting there and then having the appointment and having to drive back. It's a lot of time. I mean, one example that I give in terms of the negative externalities of healthcare, one of our staff members, one of our team members, her father hurt his back, and they live in a place called Whitney, which is on a normal day without traffic, a 20-minute drive to the Oxford Hospital. But on a bad day, it's about an hour and a half. So it took them an hour and a half to go to and from their home to the hospital, and an hour and a half to go back. So that's 3 hours. The doctor was late, so they, by 2.5 hours. So we're now at 6 hours. And then they had to wait 3 hours to get their meds at the hospital pharmacy. So we're at 9 hours. But it's not 9 hours, it's 9 hours times 3, because it was the father, the mother, and the daughter. So you have 27 hours of citizen time in the palm of the healthcare system's hand. So I think some face-to-face interactions are absolutely necessary and definitely helpful. But I think digital can also help in terms of reducing some of these waiting lists and also just improving patient experience. And I think, again, like Sven mentioned, last week's talk from Dr. 24, I think, is an example of that. And then also one of the startups that we're working on, working with value-based managed care, I think is a great example of this for just optimizing patient care and patient pathways for people with at risk of needing hip replacements or knee replacements.
Let me see. I think there's one philosophical question that just came up. And did we have something else up here? No, right? Okay. So, David, one philosophical one. Do you think Apple, Google need to step in this space to make a big change, and that China will be much faster with innovations and we will just start using their services? Oh, wow. Do you want to, Anant? Should I?
Well, why don't we can both. Do they need to step in this space? By need, do you mean whose need? Is that for them in terms of market share and their bottom line, or need from a population perspective in terms of we need people and innovators like that to actually come into the space to make things viable? From a population perspective, I think there's a lot of basic things that we can do to actually help our populations and our citizens. And again, if we're looking at, I think digital health has an important role to play, but there's a lot of basic things like providing, nutritious food, making sure that people have jobs. Then there will be people recovering from substance abuse or domestic violence, where something like digital health could have a role to play. Apple is sort of getting into this space already with their Apple Watch and the New England Journal of Medicine clinical trial that they published a few months ago on the Apple Watch for rhythm disorders. Google has been in this space for a while with Google DeepMind. IBM is in this space as well. And then obviously with Haven Healthcare, you have Amazon, JP Morgan, and Berkshire Hathaway getting into this space as well to start off with their employees. But I think eventually it'll probably evolve into something that will be on the marketplace. China, I think via Alibaba, is already getting into this space. So I think they're already thinking of getting into this space. And I think the capital requirements of getting into healthcare and the time and the patience required, like pharma, is really cash rich and is able to actually invest and sustain that need for continuous investment into before they're actually able to see a return on investment. I think the Apples and Googles and large companies like Alibaba, Amazon, etc., will probably be able to afford to get into this space. And then you would have the trickle-down effect, where you have these big companies that are able to almost establish an ecosystem. This is my view. Like the pharma companies are able to establish an ecosystem for different therapy areas. And then you can get the academics and some of the startups coming in, and they can get some of the startup funding, and then they can get bought out by the pharma companies to actually do the latter trials because they're so cash rich. So in this sense, in digital health, because Apple and Google and some of these other companies are so cash rich, they can actually come in and fund the clinical trials to get into that sweet spot, in Sven's diagram. Yeah, Sven, over to you.
Fully second everything. Then the China bit sounds a bit also looking at the government perspective, or not just the companies. And yeah, I mean, I don't want to go into sort of ethical discussions, but I do hear a lot of people in Europe complaining about the difficulty of launching new innovations and of even getting a chance to test things and ripening them and so on. And sometimes it doesn't seem like it's only a matter of money or how good your idea is and so on. And that, in a sense, might actually create a disadvantage. The other question is, there will be areas where it will be very difficult to just use technologies from elsewhere. We had Bart de Witte earlier commenting on cultural issues. We have sometimes genetic issues where just diseases are different. So you might actually run into an overfitting problem if you use an algorithm that has been trained on a population that is very different in terms of habits, in terms of genetics, in terms of nutrition, et cetera, and then just adapt it somewhere else. So I think we will have a lot of learnings to make that are different than what challenges we had to solve in the purely physical world of drugs and of hardware medical devices.
I suppose just to follow on to that, I mean, whether it's China or not China, I think is sort of immaterial. If we look at the global scheme of things, I mean, everything has been so US dominated. So if you were a non-US country, you know, is it fair that so many of the innovations came from the US and so you can almost turn it in the same direction? Or Germany for pharmaceuticals or Switzerland for pharmaceuticals? Was it fair that these were the three key hubs for these sorts of innovations? So if China has a first mover advantage and has the infrastructure to actually deliver, then I think from a population health perspective and from a health perspective, where the innovation comes from is probably immaterial unless, you know, they're using it to fund terrorists or something like this, which I don't think China is doing. And so, I mean, I think the key thing is just having the good innovations there so that we can actually benefit people. That would be my view on this, but I do realize that it's quite controversial.
Okay, I think that concluded the last question. Thank you very much, everybody, for sticking with us. We overran 10 minutes, but I very much enjoyed these questions. We are still available. Here you will find our contact details. We're also on LinkedIn, obviously, if you want to connect. We will be doing more of those. And I particularly would like to express my thanks to Anant for making time. It's always a pleasure to work, speak, engage with you.
Likewise.
Thank you. And thank you also, Lily and the FoundersLane team for setting all of this up, which is highly appreciated. But especially thanks to all the guests for joining and for the good questions. Do you have any other comments, Anant?
Great. It was thanks for inviting me and hosting me. This was fantastic and great questions.
Beautiful. See you soon in the virtual space, everybody. Stay safe and have a good rest of the evening. Bye.
Bye.